So I'm going to talk about some descriptors. First of all, where are my fellows? Is Surgeon Sasso here yet? Sorry? Tell them to get their ass down here, okay? Marvellous. Okay? I'm sorry, yes. So I need to abuse my clinical fellows. I need them down here. So this is IOTA. IOTA, as you can see, is trying to get agreement in Europe is a very, very difficult thing because we have a lot of differences between all of these countries. And this is a country where something called head cheese is in fact a national culinary dish, so you have to worry about it. So if any of you are feeling unwell this morning, having eaten out in Leuven, I can understand it. So clearly Dirk Timmerman is a master of diplomacy to be able to pull together these disparate elements into one. I work at Imperial College in London. I like to show this slide, because those of you who know London will think that we live in a very fancy place and that might be my office. Unfortunately, it isn't. I'd like to think I can wander to Hyde Park and go to Harrods. Sadly, Imperial College also owns Queen Charlotte's Hospital, which is here, which is handily placed next to the high-security prison Wormwood Scrubs. So it's not quite as sort of fancy and high class as I like to pretend. And obviously there's a lot of movement between the hospital and the high-security prison, because we're clearly a very ethical and moral department. Where are my fellows? Who's come in? Okay. Surgeon, are you in the house? Because you're late, you're going to sit at the front and be asked questions. Come on, down here. Mayor? Okay. Surgeon, how many years, what year in training are you, surgeon? Year 3, right. Okay, so you're not that experienced. Sit at the front. Now, in the meantime, I also am visiting professor at KU Leuven. All of you will have seen this and been quite puzzled as to why this place, you have a hospital this size, meanwhile Leuven is this size. Now, the proximity of the centre of the European Union, 20 miles down the road, may have nothing to do with the fact they managed to fund this highly unambitious university. And for anyone else in Belgium, just to let you know, I came across their master plan behind a table just recently. And this eventually is going to represent the surface area of the Leuven Hospital in respect to the entirety of the west of Belgium. So be very afraid. Sorry, Dirk, that's completely wrecked your political ambitions, obviously. Now, I'm just going to talk about very simple stuff. We've had some proper science, and Dirk said, well, you're very simple, so talk about simple things. And I think there is some merit in doing that, because we can talk about mathematical models, and so on, which are extremely useful, and we'll talk more about them later today. But not every mass needs a model. Ultrasound, fundamentally, is about light and dark. It's about pattern recognition. It's about looking at something and recognizing it. And if you look at all these shapes, some of them will be familiar to you, and some of them will be completely random. So easy, I think all of you can pick out what these are. And personally, I've got no idea about these ones. And that's the same with ultrasound. So, if I ask surgeon, where are you? Excellent. What's that? Brilliant, brilliant, fantastic. Yeah, that's the quality of fellow we have at Imperial College. However, if I come up with this one, it's not so easy. It looks familiar. And of course, over here, it's completely vague. And that's the same, because with ultrasound, we have the same problem. But we are very good at pattern recognition. What does this look like to everybody here? Huh? Well, it might be a frog to you, but I think it's, where are you from? Belgium. What kind of frogs do you have here, for Christ's sake? Anyway, to me, I straight away, I see a face, and I see a face with strangely, with a tongue hanging out. Now, that might say something about my psychological problems, but that's what I see. And similarly, you cut open a red pepper, and perhaps I saw too many horror movies when I was a child, but to me, this looks quite scary, you know. But maybe it's just me. Point being, we're very good at recognizing very familiar patterns, and probably the thing we're most familiar with is our faces, okay? And that's something which we see in everything. It's quite a well-known phenomenon. So we're good at it, and the more you see of things, the better we get at it, which is why you keep, we'll see faces or frogs. Frogs? Here, okay? There's always one. Now, I always show this slide because it's quite amusing to amuse radiologists. What's wrong with this? Anything? Anybody? Toon. Senior gynecological oncologist from Maastricht. What's wrong with this? Sorry? There's a metastasis. No, there's a gorilla up here, okay? all those MDT meetings, what was it all about? I don't know. But don't worry, 80% of senior radiologists in America get this wrong because, one, they're American, which is fair enough. Misty, are you here? Sorry about that. Nothing wrong with that, but it's true because it's quite a well-known test. And the reason is, of course, they're so keen looking for metastases, they don't see the bigger picture and they miss the fact there's this ridiculous gorilla sitting up there. So you've got to be careful because if you're so familiar with what you see, sometimes you just miss the obvious. And that's the thing, again, when you're talking about pattern recognition and ultrasound, you've kind of got to be, not over-familiar with the images. Just sometimes take a step back, don't focus on what's just there, and don't miss what's beyond the field of view. So it's a joke, but it's a serious point, actually. So we're very familiar with patterns, but we can become over-familiar with patterns. We assume that what we're seeing is what we always see. And that's another sort of downside of ultrasound. So if we apply the slide I showed you before and apply it to ultrasound, we have easy, and I'm going to talk about simple descriptors where pretty much anyone is going to get those right because they're not that difficult. Okay, so it's a dermoid or bilateral endometrioma, simple cyst, that's obviously cancer, hemorrhagic cyst, and so on. They're not difficult. You don't need a fancy model. Personally, I see that and then I scrabble around trying to pick out IOTA things to tick off because I've already decided very quickly what it is. So I'll say, it's an endometrioma, excellent. So, ground glass, studied, all the rest of it. I know what it is straight away. You've got some more where it's not so easy, and then you've got ones where you need help. And actually that's been the theme throughout the meeting, hasn't it? There are masses, and there's a group of masses, whatever we do, unless you're using adnex, where you're going to have a problem. So I'm going to talk about descriptors, which is just a simple way of saying, look, that's what it is, straight away. Dirk is going to talk about simple rules, and we've talked about them yesterday, but he's going to go into more detail, where you can apply rules, which will deal with about 80% of masses. And then we're left with this group up here, which, are potentially more difficult, where we need help. And because in this group, they're complicated, they've got a high prevalence of malignancy anyway. So if you don't have MRI, if you don't feel comfortable with making decisions about these more complex masses, you can just assume and just say, look, they're all cancer, send them to a gynecological oncologist. Let's face it, if it's a 1 in 2 chance of cancer, I don't think someone would complain about doing that. But equally, and we'll hear from Isabel Thomas and Nagara later, there may be a role for MRI here to sort these patients out, or equally, we could send them all to Dirk Timmerman so that his hospital can expand throughout Europe. Who was that phone? Oh, okay. It was a rubbish ringtone. Anyway, that's all I can say. So, this lot, quite easy to sort out. This lot, we need help. That's kind of how I see it. Or, as we've heard, yesterday, you have a model that will apply to all of them. And actually, Dirk and Ben are going to talk about a situation where you can also extend simple rules to give a risk for all the masses as well, which is a new thing which they're going to talk about in a minute. But let's just first talk about things where we don't really need anything. Because a lot of people get a bit confused with IOTA. And we were in America recently, and they said, well, what do you do with physiological hemorrhagic cysts? And I think probably for us in IOTA, personally, I think it's been a mistake that we haven't had part of our IOTA stuff that has addressed, the physiological cysts, because still people have operations for 10 centimeter, 8 centimeter hemorrhagic cysts around the world, which are going to go away, and so on, because there are no fixed rules. But let's just think about these cysts for a minute. What is this? hemorrhagic cyst, very easy, right? You've got some little, fibrin strands here, very simple. So you don't need any descriptors or models. You see that, it's a hemorrhagic cyst, thanks very much. Come back in a few weeks or whatever. It's almost certainly going to resolve. Okay? What about this? Ahmad. Hemorrhagic cyst, again, very simple, but people occasionally get confused because of clot retraction. Again, you don't need anything, you just say, right, hemorrhagic cyst, physiological, not a problem. Same situation. But you can get these, with one image, you can get hemorrhagic cysts that look more and more like they might have a bit of solid tissue in them, and occasionally they can be, you see them to start with, and you think, ooh, what's that? Often, as we know, it's dynamic, so you can push them, and the jelly will wobble around. And there'll be no flow inside there, which is why Doppler can be helpful. But occasionally, physiological cysts look a little bit more difficult. What about that? Who's sitting quietly over there? Jessica Farron. What do you think? Guess. Not here all day. Well, it's a hemorrhagic cyst, and that was retracting clot that wobbled around, actually. It wasn't an endometrium, and it went away. So, but immediately, you kind of look at it and think, it's not. So there are grades of these cysts. I think we should be looking at them in IOTA, personally, because, they do go away. So these are cysts which are common. They don't fit into what we do. Okay, now, who's here? My wife. Where are you? Are you a gynecologist? What do you do for a living? You are a teacher. What's this? Excellent. Oh, yes. Yeah. Hang on, and? It's big and there's fluid. Bloody hell. Okay, right. As you can tell, we obviously have exciting lives at home. But that's very interesting. Anyway, yes, it's a torted ovary. So it's edematous, it's enlarged, and there's free fluid. So here we are. You don't have to be a doctor to know some of this stuff. So if that's the case, what's this? Hongbo, professor from Buckingham University, man of many talents, pretends that he doesn't work for the security services on pattern recognition. Oh, sorry, Hongbo, did I go away? What's this? It's torsion, same as the last one. Go back to Buckingham. Okay, and this is another torsion, but obviously with a dermoid cyst there. So these are cysts that don't fit into the whole IOTA paradigm. But they're important, and you just need to be aware of them and understand that. So if we're in America, and we've had discussions about what to do with these cysts, their view is, well, you've got this group, which have like stage 1, recognize them, they don't count, and then when you've got rid of this lot, you put them into simple rules, and that's essentially what happens. And then you have an abscess, and so on. So if we're going to look at some of these masses, and say some of them are very easy, some of them are a touch more difficult, okay, what are all of these? Shabnam, Bob de Wallace, sitting there quietly, fellow at Imperial. All hemorrhagic, very easy. These are, what's that? Dermoid? Already shown it, so, endometrioma. So the point is, cancer, what's that? Kidney, yes. Yeah, we took that out. What about that? Ectopic pregnancy, fine. So, actually, everyone just sees it and you make the diagnosis. So, descriptors. So this leads in to the idea that you can have structures or masses where there are very simple features that we can identify that will allow you to say, right, that's what this mass is. So we talked about simple descriptors, and we developed these, which will look at simple cysts, dermoid cysts, endometriomas, and basically advanced cancers, because these masses, a large number of them, not all of them, exhibit typical features that are easy to classify. I'm not saying all endometriomas exhibit typical features, but there's a group which I would say are typical, and then you've got the rest. But about half of them will fit into the category. Same with cancer, the same with dermoids. You don't need all these other things to identify them. So if we talk about descriptors, Clearly, these are endometriomas, and we said, right, to describe these, we're going to say they're unilocular, ground glass contents, and they're in premenopausal women. And that's because after the menopause, there's a much higher chance that you've got a malignancy in masses that look like an endometrioma. This simple cyst, unilocular, anechoic, regular walls under 10 centimeters. That's a second descriptor. These are benign descriptors. And then you've got the rest of the unilocular cysts that have different types of content. And I'll come back to the fact that this did not have a size criteria when we did this study, but we should have done, and I'll come back to it. So remaining unilocular cysts. And then unilocular mixed echogenicity with acoustic shadowing in a premenopausal woman, which is obviously meant to describe the features of a typical dermoid cyst. Okay, and then we've got cancers, 2 malignant descriptors, ascites, moderate, at least moderate color Doppler blood flow, and a postmenopausal woman. And we talked about color score, but just to remind you, this is a slide from Daniela Fischer-Over's excellent artist, but you can see what the color score is, just to remind you. And you have, you're laughing at my mother. Really? That's not very nice. Anyway, age over 50, CA125 over 100 is a final malignant descriptor. So you have these very, very simple, easy things to look at. Okay, so the question is, how do they perform? This is iontophases 1 and 2, almost 3,500 masses. We could apply the descriptors in 43%, so almost half. And in these descriptors, if you look at them, I won't go all the numbers, you can read these, but you can see that the performance is very, very good in terms of correctly saying whether it's benign or malignant. And actually, we're very good at getting the correct histology as well for simple dermoids and endometriomas. And I think that's something which we all know, but when you apply it in the real world here, you can see that you don't need anything. You're not going to find something that's going to improve very much on those sorts of, that sort of discrimination. And in terms of cancer, it's exactly the same. So by applying really easy descriptors, you're going to sort these masses out to a very high level of certainty. Quite straightforward. And that's published in this paper, which is some time ago now, but it's quite an interesting read. So here we have all the data again. How many masses can we diagnose without rules instantly? 43%. I think that's a repeat slide, so I won't bore you with that, sorry. So if we take these descriptors, the question then is, what do you do next? And if you remember the first slides I showed you, where you have very easy, a bit more difficult, where you're going to have simple rules, and then the rest. You can have a strategy, and I think this was touched on yesterday by Caroline von Holzbeck, where you have a 3-step strategy. So I know this is a very busy slide, but Dirk will talk about simple rules. But if you apply these easy diagnoses, which will apply to 43% of masses, and then you say, right, they're sorted out, what do I do with the rest? So pattern recognition effectively for taking out that whole group. And then you apply simple rules to the ones that are left. And then of those, there'll be some that simple rules don't work with. And then the rest, you get an expert to have a look at and make a judgment. Overall, 92% sensitivity, 92% specificity with a DOR of 142. So that's pretty good test performance, which stands up, actually, against any of the other IOTA approaches. Or you can just say, well, actually, I don't have anyone who's that good at ultrasound. I'm going to say they're all cancer. And as you can see, as you would expect, the sensitivity goes up to 95%. You get a slight drop in specificity, but pretty good, actually. Not bad test performance. And you're going to send these more complex masses off to a gynae oncologist anyway. This works. This sort of 3-step strategy can work very well. And it's quite intuitive because, it's what we do. Sort out the easy ones, apply simple rules, do something with the rest. To me, it makes a lot of sense. Okay, does it work when we look in other databases? Yes, it does. We're slightly obsessed with validation, as you've heard already. So we looked at simple descriptors in a previous database. This is another 2,400 masses. These are the rules. And you can see, again, when we apply the benign rules, there are no malignancies other than for simple descriptor 4, which is all remaining unilocular cysts. So you can see very good performance. And the problem here was that we did not put in that this should be masses less than 10 centimeters. If you adjust that and say, right, this rule should actually be for masses, the rest of the masses be less than 10 centimeters, there would have been no malignancies. So in retrospect, I think that was just an error in terms of how we developed the rules. And obviously the cancers, if you have ascites, moderate flow in your postmenopausal, you've got cancer. Whether you have a scan or not, if you're over 50 with a CA125 of over 100, you've got cancer, pretty much. Especially if you look like the lady I showed you and smoke like a chimney. Okay, now my batteries are going here, which is Dirk's sign of telling me to shut up and get off. So overall, we could apply descriptors to 42% of masses. We could 550 instantly categorized as benign, and only two were malignant. 465 instantly categorized as malignant, and almost all of them were malignant, and the rest will go on to simple rules, which Dirk's going to talk about. It's pretty good. You don't need anything very sophisticated. And Almo Sayasna, who I picked out, has validated this or looked at this in operators with different types of training and experience, as you can see down here. And you can see much smaller numbers, but actually when you start looking at it, the numbers are almost exactly the same as we've seen in the hands of experienced people who developed the IOTA study in the first place. So these work well, whoever it is that is using them. Interestingly, when you look at what people are like or how good they are at pattern recognition when they're not experts or if they're sonographers, this is another paper by Ahmed, which I forgive the thing it's in proof because I haven't seen it come out yet in a proper journal. But you can see here, this is where people who are sonographers or perhaps who are trainees were asked to actually say what the specific pathology was. And you can see that they're actually pretty specific, high specificity, but they have problems sometimes getting it right. And that's because not all of these masses have absolutely typical features. And they do have a particular problem sorting out between cancers, although the numbers are low. And that's where I think Adnex is going to help them, because they find it difficult to discriminate between different subtypes of cancer. But they're actually not bad. Even at the level of trying to say what is the precise pathology, they actually get it right, perhaps a lot of the time. Particularly with dermoids, endometriomas, the obvious masses that we know are pretty straightforward. I think I'm running out of time. I did want to just touch on this just to say it is all quite simple. You can have simple descriptors, be very straightforward, and you could actually look at ovaries very simply as well, with very simple bits of kit, and get the similar results and very similar measurements, and even using a handheld machine compared to a GE E8 vaginally, when you look at it, we only had 8% disagreement in terms of what we would actually do with the patient between a handheld machine abdominally and another machine done vaginally with a very high-level machine. I showed this to GE, and they're a little bit upset because they thought this was going to destroy their business. So there we are. But it can be done simply. So, what next? We've talked about descriptors. Step 2, I think, simple rules. Step 3, review by an expert. Consider that they're all malignant, or possibly we'll hear you can do MRI, or you can simply apply Adnex. And that's pretty much all I'm going to say, because I think we've been through this. So I just thought I'd leave you with a final thought, because we're in Belgium and they do a lot of cycling here. That's it. Thank you.